Let me paint you a picture. You are 71 years old. You feel good. You slept well last night. Your energy has been steady. You are walking every morning, eating reasonably well, enjoying your retirement. You go in for your annual physical, completely routine, and your doctor glances at your chart and says 4 words that sound perfectly innocent. Let's run some tests. 6 weeks later, you are sitting in a surgeon's office, not because anything was wrong with you, not because you had a single symptom, but because those routine tests found something, and that something triggered a chain of events that your body at 71 was never equipped to handle. The surgery led to a complication. The complication led to a hospital stay. The hospital stay led to a recovery that changed your daily life in ways you never anticipated. And here is the part that will stay with me for the rest of my career. That entire cascade started with a test you did not need. That story is not hypothetical. Some version of it happens every single day, in hospitals and clinics across this country. And the data behind it deserves a far more serious conversation than most people are getting from their doctors in a 15-minute appointment. I am Dr. Reid Ashford. I have spent over 20 years studying the research behind aging, chronic disease, and the medical decisions that matter most after the age of 60. And today I need to share something with you that challenges one of the most deeply held beliefs in modern healthcare. The belief that more testing always means better care. After 65, that belief does not hold up the way most people think it does, and what I am about to walk you through is not my personal opinion. It comes directly from the published guidelines of the organizations that set the standard for preventive medicine in this country, and from landmark clinical trials that changed how researchers think about intervention in older adults. This is not about rejecting medicine. I believe deeply in medicine. This is about understanding when medicine helps you and when it quietly works against you. Before I walk you through the 5 checkups, I need to give you one idea. Because without it, everything I am about to say will sound reckless instead of reasonable. I call it the screening equation. When you are 50 years old, preventive screening is one of the most powerful tools in medicine. You find a small problem early. You treat it while your body is resilient. You potentially gain 30 or 40 years of healthy life because of that early catch. The benefit is enormous. The risk is small. The math is overwhelmingly in your favor. But after 65, 3 variables in that equation shift simultaneously, and they shift in a direction that most patients are never told about. Variable 1. Many of the conditions that screening detects in older adults grow so slowly that they will never produce a symptom in your remaining lifetime. You would live alongside them and never know they were there. You would not die from them. You would die with them. But the moment they appear on a report, they get treated as if they are an emergency. Variable 2. Your body's ability to tolerate intervention decreases with every decade. The surgery that a 55-year-old recovers from in 2 weeks can put a 75-year-old in bed for 3 months. The anesthesia that a younger body processes cleanly can destabilize an older body's blood pressure, cognition, and kidney function. The risk of the fix starts to rival the risk of the problem. Variable 3. And this is the one that concerns me most. There is something in medicine called the cascade effect. One routine test finds a borderline abnormality. That abnormality triggers a follow-up scan. The scan recommends a biopsy. The biopsy leads to a procedure. The procedure causes a complication. And suddenly, a person who walked into their doctor's office feeling perfectly fine is navigating a medical crisis that originated not from disease but from detection. That is the screening equation. Benefit versus risk versus cascade. And after 65, the balance of that equation is not what most people assume. Keep that framework in your mind. It applies to every single checkup I am about to name. I am going to walk you through 5 routine medical checkups that I would personally decline after the age of 65 if I had no symptoms. Number 3 is the one that surprises people the most because it sounds like the most responsible thing a doctor could recommend. And number 5 is the one that almost nobody has heard of until the consequences are already in motion. Let us start with number 1. Most people believe that colonoscopy is something you should continue doing indefinitely as you get older because colorectal cancer risk increases with age. That logic sounds airtight. More risk means more screening. It seems obvious. But here is what that logic misses. The United States Preventive Services Task Force, which is the independent panel that sets evidence-based screening guidelines for the entire country, specifically recommends against routine colonoscopy screening for average-risk adults over the age of 75. Not because colorectal cancer stops being dangerous. It does not. But because the risks of the procedure itself begin to outweigh the statistical benefit of finding something in a body that may never be harmed by it. Here is the mechanism most people never hear about. The colon cancers most commonly detected in asymptomatic adults over 75 tend to be slow-growing. Many of them would take 10 to 15 years to become clinically significant. In an otherwise healthy 77-year-old, the probability that a small, slow-growing polyp would ever cause a problem within that person's remaining life expectancy is statistically low. But the probability that the procedure itself causes a problem is not low at all. Think of it like inspecting the foundation of a house you are not planning to renovate. The inspector finds a hairline crack. The crack has been there for decades. It is not growing. The house is structurally sound. But the inspection report says, "crack found." And now you are hiring a contractor to dig up the foundation. And the digging causes a pipe to burst that floods your basement. The original crack was never going to cause damage. The inspection did. The data on procedural risk is specific. Bowel perforation, which is a tear in the wall of the colon caused by the scope, occurs in approximately 1 out of every 500 colonoscopies. In a younger adult, that is a manageable surgical complication. In a 78-year-old with thinner tissue, slower healing, and less physiological reserve, a bowel perforation can mean emergency surgery, a colostomy bag, weeks in the ICU, and a recovery trajectory that permanently alters independence. And that is before accounting for the bowel preparation itself, the high-volume liquid prep required to clear the colon before the procedure causes significant fluid and electrolyte shifts. In older adults, particularly those on blood pressure medications or diuretics, this can trigger dangerous drops in potassium and sodium levels, leading to cardiac arrhythmias and severe dehydration. Here is what most people miss. If you are over 75 with no symptoms, no family history of colorectal cancer, and previous clean colonoscopies, there is a far less invasive option that your doctor may not volunteer. A stool-based screening test, such as the fecal immunochemical test, can detect hidden blood in the stool, which is one of the earliest markers of colorectal pathology. No sedation, no prep, no perforation risk. You do it at home. And if it comes back positive, then you have a clinical reason to pursue a colonoscopy where the benefit clearly outweighs the risk. The distinction is not between screening and no screening. It is between invasive screening that carries procedural risk and non-invasive screening that provides a meaningful safety signal without putting your body through an event it did not need. This one requires precision, because the conversation around prostate screening has been genuinely contentious in the medical community for over a decade. And I want to be exact about what the evidence says. The PSA test measures a protein produced by the prostate gland. Elevated levels can indicate cancer, but they can also indicate a dozen other conditions, including benign prostatic enlargement, recent physical activity, urinary tract infection, and even the simple act of riding a bicycle. The fundamental problem is specificity. The PSA test is highly sensitive, meaning it detects abnormalities frequently, but it is poorly specific, meaning a large percentage of those abnormalities are not cancer. And the downstream consequences of a false positive in a 72-year-old man are not trivial. An elevated PSA leads to a prostate biopsy. A prostate biopsy involves inserting a needle through the rectal wall into the prostate gland, typically 12 times, to collect tissue samples. That procedure carries a clinically significant infection rate. A systematic review published in the journal European Urology found that post-biopsy infections requiring hospitalization occur in approximately 3 to 5% of cases. In older men with comorbidities, that infection can escalate into sepsis. And here is where the screening equation becomes critical. Even when a biopsy does find cancer, a substantial proportion of prostate cancers detected in men over 70 are low-grade, slow-growing tumors that fall into a category pathologists describe as clinically insignificant. These are cancers that based on their biology, would be unlikely to spread, cause symptoms, or shorten life within the patient's expected remaining years. Think of it like a speed camera on a road with a 5-mile-per-hour speed limit that nobody actually drives. The camera catches everything. A delivery truck going 6 miles per hour, a bicycle coasting at 7. Every single one gets flagged. But the flagging itself creates more disruption than the speeding ever would have. The detection system is too sensitive for the actual level of threat. The USPSTF recommends against routine PSA screening in men over the age of 70. Their analysis concluded that the harms of screening, including overdiagnosis, unnecessary biopsy, biopsy-related infection, and overtreatment of indolent cancers, outweigh the benefits in this age group. The landmark PIVOT trial, published in the New England Journal of Medicine, followed men with localized prostate cancer for nearly 20 years and found no statistically significant difference in overall mortality between those who had surgery and those who were simply monitored. What most people miss is that there is a middle path. If you have a strong family history, or if your PSA has been rising consistently over several years, your doctor may have a clinical rationale for continued monitoring. But that is individualized surveillance, not routine screening. The distinction matters. One is a targeted decision based on your specific risk profile. The other is a blanket protocol applied to every man who walks through the door, regardless of whether it serves him. The question to bring to your doctor is direct. If this PSA test comes back elevated, what is the next step? And what are the risks of that next step at my age? That single question changes the entire conversation. This is the one that surprises people the most, because it sounds like the most prudent thing a doctor could possibly suggest. Your doctor says you are 68 years old. Let us just check how your heart is doing. You walk on a treadmill while they monitor your EKG. Or they inject you with a medication that simulates the cardiovascular effects of exercise, and they watch how your heart responds. It sounds thorough. It sounds responsible. It sounds like exactly what a careful doctor should do. Here is what the research says about what happens next. Cardiac stress tests performed on people with no symptoms have a false positive rate that ranges from 25 to 40% depending on the population and the testing protocol. That means in up to 4 out of every 10 asymptomatic people tested, the results will suggest a cardiac abnormality that does not actually exist. But medicine cannot ignore an abnormal result. An abnormal stress test triggers a cardiac catheterization. That is a procedure where a thin tube is threaded through your blood vessels, typically through the wrist or the groin, directly into the coronary arteries of your heart. The catheter injects dye, and fluoroscopic imaging shows the cardiologist where blood flow may be restricted. Cardiac catheterization is not a benign procedure. It carries documented risks of bleeding, blood vessel damage, arrhythmia, contrast dye reactions that can damage the kidneys, and in rare but real cases, the procedure itself can trigger the heart attack or stroke it was trying to prevent. In older adults with less elastic blood vessels and reduced kidney function, those risks are amplified. And here is where the cascade reaches its most counterintuitive point. If the catheterization reveals a partial blockage, and partial blockages are extremely common in adults over 65 who have zero symptoms, the cardiologist may recommend placing a stent. A stent is a small metal scaffold inserted into the artery to hold it open. The ischemia trial, one of the largest and most rigorous cardiology trials ever conducted, enrolled over 5,000 patients across 37 countries and followed them for a median of 3.5 years. The results, published in the New England Journal of Medicine in 2020, found that in patients with stable coronary artery disease and no acute symptoms, invasive intervention including stenting did not reduce heart attacks, did not reduce cardiac death, and did not extend life compared to optimal medical therapy alone. Think of it like calling the fire department because your smoke detector beeped once. The firefighters arrive, they break down the door, they flood the kitchen with water, and when the dust settles, they find that the detector had a low battery. The house was never on fire, but now you need a new door and a new kitchen floor. The response caused more damage than the original signal ever would have. What most people miss is that the interventions that actually reduce cardiac risk in a 68-year-old without symptoms are not procedures. They are management strategies: blood pressure optimization, cholesterol management with statins when indicated, blood glucose control, a consistent daily walking routine of 30 minutes or more, smoking cessation if applicable. These interventions have decades of robust evidence behind them, and they carry essentially no procedural risk. If you have no chest pain, no unexplained shortness of breath, no dizziness during exertion, and no episodes of unusual fatigue during activity, a routine cardiac stress test is looking for a problem in a population where finding a problem is common and fixing it does not reliably improve outcomes. The screening equation does not favor it. I want to pause here for a moment. We have covered 3 checkups so far, and each one follows the same pattern: a test that sounds responsible, a finding that sounds alarming, a treatment that sounds necessary, and an outcome that does not reliably improve the life of the person who walked in feeling well. Which of those 3 surprised you the most? I want you to drop the number in the comments right now. 1, 2, or 3. I read every comment on this channel, and the pattern I see in those answers directly shapes what I cover in the next video. Your answer tells me where the biggest gap in understanding is. That matters. Now let us continue. Number 4. I want to be careful with this one because osteoporosis is a real condition. Falls are devastating in older adults, and I am not suggesting that bone health does not matter. It does, profoundly. What I am questioning is the automatic pipeline that connects a DEXA scan result to a long-term medication prescription without a serious conversation about what that medication actually does over time. A DEXA scan measures bone mineral density. It produces a score called a T-score. If your T-score falls below a certain threshold, you receive a diagnosis of osteopenia or osteoporosis, and in many clinical settings, the next step is a prescription for a bisphosphonate medication such as alendronate or risdronate. You take this medication weekly or monthly, sometimes for years, with the understanding that it is protecting you from fractures. Here is the part of that conversation that often gets compressed into a single sentence or skipped entirely. Bisphosphonates work by slowing the natural process of bone remodeling. Your bones are not static structures. They are living tissue that constantly breaks down old bone and builds new bone. Bisphosphonates inhibit the breakdown phase, which increases bone density on a scan. The number looks better. But the bone itself becomes more brittle over time because it is not being renewed. This creates a paradox that the medical literature has documented extensively. Long-term bisphosphonate use, typically beyond 5 years, is associated with a specific type of fracture called an atypical femoral fracture. These are stress fractures that occur in the shaft of the thigh bone, often with minimal or no trauma. The bone simply breaks because it has become rigid and unable to absorb normal forces. A meta-analysis published in the Journal of Bone and Mineral Research confirmed that the risk of these atypical fractures increases significantly with prolonged bisphosphonate use. Think of it like treating a leather jacket with a sealant to prevent cracking. At first, the jacket looks stronger. The surface is firmer. But over time, the sealant prevents the leather from flexing naturally. One day, you reach for something on a high shelf and the sleeve splits at the elbow. The treatment that was supposed to prevent damage caused a different kind of damage. Additionally, long-term bisphosphonate use has been linked to osteonecrosis of the jaw, a condition where the jawbone tissue begins to deteriorate. It is uncommon, but when it occurs, it is painful, difficult to treat, and disproportionately affects older adults who are also undergoing dental procedures. Here is what most people miss, and this is where the data genuinely shifts the conversation. The single most effective intervention for preventing fractures in older adults is not a medication. It is fall prevention. A landmark analysis published in the BMJ evaluated the comparative effectiveness of pharmacological versus non-pharmacological interventions for fracture reduction in adults over 65. Balance training, particularly programs like Tai Chi, reduced fall risk by approximately 28%. Home hazard modification, removing loose rugs, installing grab bars, improving lighting, reduced falls by a further measurable margin. Vision correction, medication review to eliminate drugs that cause dizziness, adequate protein intake, and vitamin D sufficiency each contributed additional protective benefit. Combined, These interventions reduce fracture risk at least as effectively as bisphosphonates in most moderate-risk patients, and they carry no pharmaceutical side effects whatsoever. The conversation you should have with your doctor is specific. Before we discuss medication, can we review my actual fall risk factors? What is my fracture risk based on my age, weight, activity level, and history? And what is the evidence that this medication will meaningfully reduce my fracture risk beyond what a structured fall prevention program would accomplish? Those questions are not confrontational. They are exactly the questions that the evidence supports asking. This is the one that almost nobody has heard of until they are already sitting in a vascular surgeon's office wondering how they got there. A carotid artery ultrasound is a non-invasive imaging test where a probe is placed on your neck to visualize the two large arteries that carry blood from your heart to your brain. The purpose is to detect narrowing caused by plaque buildup, a condition called carotid artery stenosis. The logic is straightforward. If we find a significant blockage before it causes a stroke, we can fix it surgically and prevent the stroke from ever happening. That logic makes intuitive sense. It also falls apart when you examine the data in asymptomatic patients. The surgical procedure used to treat a carotid blockage is called a carotid endarterectomy. It involves opening the artery in your neck, physically removing the plaque, and closing the vessel. In experienced surgical hands, the procedure has documented benefit for patients who have already experienced symptoms: a transient ischemic attack, episodes of temporary vision loss, facial drooping, or arm weakness. For those patients, the data clearly supports intervention. But for patients with no symptoms whatsoever, the calculus is different. The procedure itself carries a 2 to 3% risk of causing the very stroke it is intended to prevent. During the operation, a small piece of plaque can dislodge and travel to the brain. In older adults, particularly those over 70 with other cardiovascular risk factors, that perioperative stroke risk is at the higher end of the range. The USPSTF explicitly recommends against routine carotid artery screening in asymptomatic adults. Their systematic review concluded that in people without neurological symptoms, the harms of subsequent surgical intervention, including stroke, myocardial infarction, and cranial nerve injury, outweigh the expected benefit of stroke prevention. Think of it like clearing a fallen tree from a path in the woods that nobody walks on. The tree has been there for years. The path is overgrown. Nobody is using it. But someone sees the tree on a survey map, sends a crew with chainsaws, and during the clearing they accidentally damage a power line that runs along the path. Now there is an active electrical hazard, where before there was just a quiet obstruction that was bothering no one. Many people over 65 have some degree of narrowing in their carotid arteries. It is an expected consequence of decades of normal vascular aging. In most cases, that narrowing is stable, asymptomatic, and managed far more safely with medical therapy than with surgery. Blood pressure control, statin therapy, antiplatelet medication when indicated, smoking cessation, and regular physical activity are the frontline interventions for asymptomatic carotid disease. They carry a fraction of the risk of surgery and, in the asymptomatic population, produce comparable or superior outcomes. What most people miss is the symptom awareness that makes screening unnecessary. If you experience any transient episode of vision loss in one eye, any sudden difficulty with speech, any momentary weakness in an arm or leg, or any sudden severe headache unlike anything you have experienced before, those are potential warning signs that warrant immediate evaluation, including carotid imaging. In the presence of symptoms, the risk-benefit equation shifts dramatically in favor of intervention. But without symptoms, looking for a blockage you cannot feel, and that may never cause harm, is a screening decision where the screening equation does not support routine testing. Now let me bring all 5 together, because I do not want you leaving this video with anxiety. I want you leaving with a tool you can use at your next doctor's appointment and every appointment after that. I call it the 4-question shield. These are 4 questions you bring with you, written down, every time your doctor recommends a screening test. They are not confrontational. They are not about rejecting medicine. They are the exact questions that the evidence says you deserve answers to before you consent to any procedure. Question 1. What is the false positive rate of this test in someone my age? This tells you how likely the test is to flag something that is not actually a problem. If the false positive rate is 30 or 40%, you now know that there is a meaningful chance of being launched into a cascade of follow-up testing for a finding that was never real. That context matters before you agree. Question 2. If this test finds something, what would the treatment be? And what are the documented risks of that treatment for someone my age? This is the question that collapses the distance between a screening decision and a treatment decision. Most patients think of screening as a separate low-stakes event. It is not. Screening is the first domino. This question forces the full chain of consequences into the room before the first domino falls. Question 3. What is the clinical evidence that treating this finding in someone my age actually improves outcomes compared to monitoring it? This is the ischemia trial question. This is the pivot trial question. In many cases, the honest answer is that treatment and monitoring produce equivalent outcomes, but treatment carries procedural risk that monitoring does not. If your doctor cannot cite specific evidence that intervention outperforms watchful waiting for your age group, that is critical information. Question 4. Is there a less invasive way to get the same safety information? A stool-based test instead of a colonoscopy. A clinical risk assessment instead of a DEXA to medication pipeline. A structured fall prevention program instead of long-term bisphosphonates. Blood pressure and cholesterol management instead of carotid surgery. In almost every case on this list, a less invasive alternative exists that provides meaningful protection without the procedural risk. Write those 4 questions down, put them in your phone, print them and put them in your wallet. Bring them to your next appointment. Any good physician will welcome them. They will respect you for being informed, and they will give you better care because of it. If your doctor dismisses these questions or makes you feel difficult for asking them, that tells you something important too. Not about the questions, about whether that particular doctor is the right fit for the kind of care you deserve at this stage of your life. I want to be clear about something before I let you go. I am not telling you to avoid medical care. I am not telling you to skip appointments. I am not telling you to ignore symptoms. If you have blood in your stool, get a colonoscopy. If you have chest pain, get a stress test. If you have had a transient episode of vision loss or facial weakness, get that carotid artery evaluated immediately. Symptoms change the equation entirely. Every single recommendation I have made today applies specifically to routine screening in the absence of symptoms. What I am telling you is this. After 65, you have earned the right to ask what a test is looking for, what happens if it finds something, and whether the treatment would genuinely improve your life or simply extend your anxiety. Preventive medicine is at its best when it is a conversation, not a conveyor belt. When your doctor explains the reasoning, when you understand the trade-offs, when the decision is made together based on your health, your goals, and the best available evidence. There is a difference between medicine that finds things and medicine that helps you live well. The best doctors I have encountered in my career understand that after 65, the goal is not to detect every abnormality. The goal is to protect the life you are actually living. You are the expert on your own life. Your doctor is the expert on medicine. The best outcomes happen when those two forms of expertise meet in the same room with mutual respect and a shared understanding of what matters most to you. If this changed how you think about your next doctor's visit, the next video goes deeper. I am covering the 5 common medications that the research increasingly suggests should be reconsidered after 65, including one that over 40 million Americans take every single day without ever being told about the cognitive risks that accumulate with long-term use. That one has stopped people in their tracks. I am Dr. Reid Ashford. Make informed decisions, ask better questions, and protect the health you have worked your entire life to build. I will see you in the next one. Everything I have shared today is based on published clinical guidelines, peer-reviewed research, and the documented recommendations of the United States Preventive Services Task Force. This is educational content designed to help you have better conversations with your own physician. It is not a substitute for personalized medical advice. Your individual risk factors, medical history, and health goals are things only your doctor can assess. Please consult your physician before making any changes to your screening or treatment plan.